Good morning and welcome to Grand Rounds. Thank you for being here. Our guest speaker today is Dr. Anita Jeyakumar. We're very excited to have her here. She joined the Carilion Clinic 6 months ago in August, pediatric ENT, and she's going to talk today about pediatric cochlear implantation. Dr. Jeyakumar did her ENT residency at the University of Rochester and her pediatric ENT fellowship at the Cleveland Clinic. I still have to ask her if she did Dr. Me. Oh, you did? Yeah. And also want to welcome our fourth-year students interviewing for our residency program. Thank you and welcome.
Hi, everyone. Good morning. Good morning. So I've been given all kinds of technical guidance, so I'll try not to botch it.
Just click one.
Click one?
Click one, so it'll take you to your...
Sweet. Okay, perfect. So first to start with the formalities, no disclosures. I tend to be a sort of informal, interactive speaker. So I'm going to ask questions, and they're not directed at anyone particular, so I'm not pimping. Our goals today are pretty broad. We're going to talk about newborn screening. We're going to talk a little bit about fundamentals of cochlear implantation, what you need to know even if you meet the odd hearing impaired patient. And then we're going to talk a little bit about modern advances. At the end of my talk, I have some videos. Hopefully that will tie things in, and we've really troubleshooted this video, so hopefully they'll work. I figured we'd have a mixed audience. I've been told to use my mouth. So the ear, fundamentally, in med school, you're taught is divided into 3. I'm going to tell you it's divided into 5, because you don't hear from your ear, you hear from your brain. Your brain needs to get the sound input for it to process it and understand that it's sound. And we'll tie with this in later. The ear, the outer third is the outer ear. Middle ear is where the hearing bones are. And for the purposes of most of this talk, we're talking about the inner ear, the cochlea, or the hearing organ, which then sends a signal to the nerve, which then sends a signal to the brain, which needs to be processed as sound. And we do have a video later that shows the physiology of all of this. So the highlight of this is the incidence of hearing loss. Why do we care about hearing loss? What does it matter? Many of us want to meet hearing loss. Some of this we'll show is much more relevant. In terms of incidence, 2 to 4 infants per 1,000 births are born with hearing loss. 1 in 1,000 infants are born profoundly deaf. It is not an issue of just pediatrics. We'll talk about that later. But when you talk about it in comparison with other childhood diseases that we screen for, you can see that when you talk about hearing loss versus PKU, hypothyroidism, sickle cell disease, by and far, hearing loss is much, much, much more common. So the fact that some of us may not know a person with hearing loss doesn't mean that they don't exist. It's just that it's the common thing. It's an invisible disease. So as long as it's invisible, it's very comfortable for a lot of people to not acknowledge it or think it's okay. But invisible disease still causes problems, and we'll talk about that as we go along. If you have hearing loss, it'll impact your speech. It'll impact your language. If you have an issue with speech and language, it'll affect your literacy. It'll affect your ability to perform socially and cognitively. You will then have difficulty in school. You will then have difficulty getting a job, and then that'll affect your socioeconomic opportunities. So when you look at data nationally, it shows that people who are of lower socioeconomic status tend to have a higher incidence of hearing loss. But it's a little bit of the chicken and the egg. Are they there because they have hearing loss, or would they have been there whether or not they had hearing loss? And I will beg to you that it's a little bit of both. Hearing loss is not a pediatric illness. It is across the board a huge problem in society. So this is just as you go up in age, as you can see the incidence in millions of people across the United States, and by the time you get to 75 and above, it's almost 5 million people who will have hearing loss. And just nationally, just to put those numbers together, once you get 65 and above, 50% of the population will have some form of hearing loss. So 95% of children who have hearing loss have hearing parents. How many of you, just for a show of hands, how many of you in the room have met someone who's deaf? That's actually pretty good, because the first deaf patient most parents will meet will be their child. So when we talk about pediatric medicine, oftentimes we need our parents to make decisions. And our parents often are the least informed people in the picture, just because they just don't have any exposure to it. And partly because most of hearing loss is recessive genes, so they can be generations in a family that will never have hearing loss. So when a baby is born, the parents are often in shock that their child has hearing loss, and they have to make decisions very quickly to make sure that the child makes progress and they don't know what they're doing. So it's really important that all of us speak sort of at least a similar language or a same language, ideally, so that way the parents get a consistent story to be able to make informed decisions. Traditionally, for hearing loss, only high-risk babies were screened. So the average age of identification was somewhere between 2.5 years to 3 years or 5 to 6 years. Anyone have any idea why those age marks?
Because that's when you should start talking.
Maybe. School, yes. So because these children started preschool and these children started kindergarten. So what will happen is that these children were physiologically not doing the things they were supposed to do, but everyone around them was saying, oh, they're fine, they'll get better, it'll be fine. And what parent doesn't want to hear that their child is fine? The parents are like, okay, they're fine, they're good, keep on moving. And then they get to school, and you know, our poor, underpaid, underappreciated teachers would say that is not fine. That child is not doing what they should do, and they would insist that they get a workup. And then you would ID those children. But by 2.5 years, a child really needs to begin their first words about a year of age. So 2.5 years, they're a year and a half behind. 5 years, they're 4 years behind at minimum. So the catch-up that these children have to do with their ID that late is a problem. We nationally recognized it was a problem. So in 1993, the NIH came out with a consensus statement that endorsed the newborn hearing screen. And after that, in 1999, Congress passed the Newborn Infant Hearing Screening and Intervention Act, which basically means that if a child is born, they're supposed to get a newborn hearing screen before they are discharged from the hospital by the first month of life. And we'll talk about that in some detail in the next slide. But the ultimate goal of newborn hearing screen is that you want a process that improves long-term developmental outcomes at a population level. So does a screening guarantee that you will capture every single child with hearing loss? It's a screen, right? So no screening captures 100%. That's just not what screens do. So likewise, a screen is also going to capture a certain amount of normalcy. But I think as a society, we over-assume how many normal kids are captured and under-assume how many abnormal kids are missed. But that's just the nature of the screen. It's sort of what we have now. But we also do know that early language development means that they're going to have better educational outcomes and educational achievement down the road. So the earlier you identify them, the better they do later, because the earlier you intervene with them, the better they do later. So we adopted this in 1998, and as you can see, this is just sort of a smattering of the states. We were kind of right in the mix. We weren't super early, we weren't super late. And overall, as far as newborn screening goes, we're doing a pretty good job. But the process after newborn screening, we are not doing a very good job across the country. So this is an important slide. Sorry, let's use this. So I'm going to stick on this slide a lot. This is what I call the 136 rule. So for our trainees, if there's one thing you leave with here is 136. And you should dream about 136 because everyone in here hopefully is going to encounter babies and you're going to take care of children. So what does 136 mean? It's sort of the guidance of what we do with newborn hearing screen. So as I said, the law says that a baby who's born has to have a newborn hearing screen before they leave the hospital. Now, the exceptions to this are that it does not apply to home births. It does not apply to some birthing centers. So it is not going to capture 100% of babies, but hopefully it'll capture most. The hearing screening can be done with OAEs and ABRs. And another note of that is that the hearing screening is normally done by someone who knows nothing about hearing loss. It's usually just a process. It's a checkbox. So what they do is they'll come with this little machine, they'll stick inserts in the child's ear, and then they press the button on the machine and they say plus, minus, yes, no, pass, fail. I use the term fail because parents understand fail. There are a lot of terms that we use when we talk about screening. I use fail because everyone has done a test at some point. They understand what pass and fail means, and they need to understand that this is relevant. So if a child fails the first screen, they are allowed to get one more screen, not 5 more, 3 more, 8 more, 1 more screen by a month of life. And the reason for that is that if a patient goes home, as they're supposed to, if they continue having screen after screen after screen, the data shows very clearly that the parents just lose interest because they don't understand what they're doing, they don't understand what the relevance is, and they just stop coming. So we end up losing over 40% of our kids nationally who fail their initial newborn screen when we don't do the follow-up testing properly, 40%. So even though we're doing the screening well, after that we're not doing a good job. And that's because a lot of places are doing things differently. So they're allowed to have one more screen by 1 month of life. If they fail that second screen, then they have to get diagnostic testing, which needs to be done by 3 months of life. So the 3 in the 1, 3, 6. And that's relevant for many reasons. One is that for diagnostic testing, that means a full-blown, essentially auditory test in a baby. So now, can a baby do yes, no? What do you think? No? No, right? I mean, they shouldn't. If they do, you should report it or something. So they can't. So what you're doing is that you're basing it on their physiology. So when babies are newborns, what are they able to do? They basically feed, they poop, they cry, and they sleep. Hopefully they sleep a lot, but sometimes they don't. So we use that physiology as long as they're young enough because what we do is we'll have a child come in and we will starve them a little bit. Not a lot. This is not NPO. We're talking about delaying a feed an hour or something like that. So they get pissed off. They get angry. When they get angry, they cry. And then we feed them when they're literally ready for the test. When you feed them and you burp them, a baby who has cried for a bit, has been hungry for a bit, gets tired, and they pass out. When they pass out, you can do almost anything to them. So we do. So we stick inserts in their ear, we stick some wires, basically like an EEG, and we measure brain waves. And we can get a true measure of hearing of each ear when we do that. We can only do that till about 3 months of age because babies are growing and they're developing. So once they hit that 3-month mark, you start to poke them and they start to wake up. And then your EEG is all jacked up because you don't know what you're measuring. So really we have a very small window where we can actually do that. If we miss that 3-month mark, oftentimes we're now talking about doing this under sedation. So you now have to introduce anesthesia into the mixture. Well, if you can't answer the question any other way, that's what we have to do. So right now, actually, you'll see in our area, we're doing a ton of sedated ABRs. Why? Because all these babies miss the window. So if we can't do it, I need to know what kind of intervention to do for the child. And I can't do an intervention if I don't know what their hearing status is. So that 3-month mark is really critical. So you can see doing that initial screening and knowing what to do from there is very, very important for us. Once they get that 3-month mark, if they have hearing loss, then we want to do the intervention by 6 months of age. Why 6 months? So when you look at data, what it shows is that by 6 months of age, a normal developing baby will respond to their name. No, they don't answer to their name. I understand that. But meaning when you call their name, they will turn to you. That is receptive language. So language acquisition actually starts at about 6 months of life in a full-term, normally developing child. So by 6 months of age, we want to make sure we have given them an ability for language acquisition. So the intervention by 6 months can be hearing aids, seeing the specialist, doing the workup for cochlear implantation if they're profoundly deaf and whatnot. But the intervention usually is by 6 months of age. So the goal being as close to 6 months of age, we have intervened in the child to help them get back on the path to progressing like they should. So 1, 3, 6. I want the residents to dream about 1, 3, 6 tonight. That is my goal for you. Okay. Questions? Yes, sir.
The ABR that you're talking about, do you do that in your office?
No, we actually are doing everything in the hospital right now. So, and that's just making sure that we're also capturing the NICU babies. We'll put a protocol in place because before we were losing 40% of our NICU babies because we weren't doing any diagnostic testing until I came. So everything is being done in the hospitals. We have protocols for the sedated ones and the unsedated ones. But if you have anyone for me, I will plug them in. So ultimately, when we talk about hearing loss, as what we're talking about is sensorineural hearing loss. There are other kinds of hearing loss that are connected with the outer ear as well as the middle ear. That is not what we're talking about today. So we're not talking about fluid today. In sensorineural hearing loss, there is a loss of these hair cells, which are cells found within the human cochlea. In the human cochlea, we do not have the ability to regenerate our hair cells. So they go, they're gone. So for those of you who listen to loud music, They go, they're gone. Just think about that when you're blasting out your headphones, because that will affect you down the road. But because they're gone, the neurons that supply those hair cells eventually don't get a signal. And nerves, like any nerve, if they don't get a signal, they kind of start to waste away. So the reason why we talk a little about that is because talk about neuroplasticity, meaning that if those neurons aren't stimulated for a period of time, that time is not completely defined yet, eventually they lose the ability to receive the stimulation. And if they lose the ability to receive the stimulation, even if you give them stimulation, they may not respond well to it. So that's why all this time crunch is so critical, because we don't know at what point we lose the ability completely to stimulate the neuron. So we're always pushing. Until we figure that out, we just need to be efficient about the process. The reason why I have this slide up here is that this is a 28-day fetus, so meaning that most people don't know they're actually pregnant yet. Ear development starts here. So we don't know at what point in this process those hair cells are lost. So you hear about a lot of people who the parents are talking to the mom's pregnant belly, or the mom's talking and the baby kicks, or they put headphones on the belly, all kinds of versions. You hear about all those things. If they get no sound at all, which possibly is what happens, that means a newborn baby who's born deaf has had no sound at all. They don't know what the wind sounds like, mom sounds like, dad sounds like, a bird sounds like. And just kind of keep that kind of mulling in the back of your head, because we'll come to it later. So for a child who is deaf, we will do a trial of hearing aids. That is required both by our conscience as well as by insurance companies. You have to show that you've done a trial of hearing aids. So again, parents will say, my child's deaf, they're sticking hearing aids to my child, I don't know what the purpose is. There are two purposes, actually. One is that we have to make sure that the parents are compliant. Does that sound normal to you guys, parents being compliant? Just because I do a surgery doesn't mean that the parents are going to do what I ask them to do. So I would rather find that out before I do a surgery than after I do a surgery. So part of it is making sure that when I put the hearing aid on, I tell the parents every waking hour that child needs to have the hearing aid in, we can measure those things. So when they come in, I measure those things. I trust but verify, because everyone will tell me they're doing it. I don't trust anybody, so I verify it. So the other is that we teach the child to wear those hearing aids, because when you introduce a hearing aid, which we can fit a hearing aid in a child as young as a month of age, when you fit it really early before they have motor function, they leave it alone. So then you put an implant in that actually benefits them, they're much more likely to leave it alone. Otherwise, if you do nothing to the ear and then you stick a whole bunch of stuff on the ear, well, what do you think a child's going to do? They're going to pull it off, because that's what any normal person would do. They're pretty normal except for hearing loss. In children who are deaf, hearing aids don't work, so we move on to the next step. So to talk about cochlear implants, there's a lot. Any questions up to this point? What's the numbers I want you to remember? Thank you. Makes me so happy. Okay, so cochlear implants are surgery, and everyone tends to focus on the surgery, but really it's a process. Cochlear implantation is a process, and it is not a light bulb. Doing the surgery doesn't make them hear. Giving them sound doesn't make them understand what sound is. But we do need to spend some time talking about the surgical part, because that is where a lot of the anxiety lies. You know, parents don't want to do surgeries on newborns, and really they shouldn't, but this is important if they want their child to be in the hearing world. There are two parts to an implant, and there are three companies. I'm not endorsing anyone, but this is the inside part of one. This is what I put in surgically. Here is a little magnet, which is how the outside part attaches to the inside part, and we'll kind of talk about that. And this is the outside part of the cochlear implant. So some people will say, oh, I don't have to wear anything with an implant. No, you have to wear something. And part of the reason why you have to wear something is that these are electrical devices and they're powered. We don't have a battery that lasts a lifetime. The longest that we have a battery, which is huge, that lasts is 10 years. So until we can get something that can be powered long enough, we have to have an external part. We also have to have something external that has a microphone, because you can't put a microphone in someone and expect it to function well, because it'll be muffled. So that's why we have an external part to a cochlear implant. And this piece over here also has a magnet. So this attaches to this, which is underneath the skin, and that's how you get sound from the outside to the inside. And I'll have a video that puts it all together. And then in a human baby, this is what it looks like. So this is the behind the ear part, which looks like a traditional hearing aid. The batteries are housed in this little casing. This is what's attached by the magnet, and this is what's implanted underneath the skin, and these are the electrodes that go into the cochlea that I put in there. So let's see if we can get this to work. So this video has a little bit of two things. It has normal physiology as well as how an implant works. And hopefully it'll tie what we've talked about together. And I tend to talk too fast for the video, so I might need to pause periodically. But, so again, ear divided into three parts. When you have sound come to the ear, the sound sends a signal. It then causes the eardrum to vibrate, which causes the hearing bones to move in this weird lever-like fashion. When the hearing bones move, this is the third hearing bone called the stapes. It moves at the oval window into the cochlea. It moves the fluid within the cochlea, which then sends waves. These waves then move these hair cells within the cochlea. That movement of the hair cells at different parts of the cochlea stimulates sound, which then sends a signal, which then goes to the auditory nerve. And then as that signal goes to the auditory nerve, it then goes to the cerebral cortex, the brain, and then it's interpreted as sound. Okay, so that's normal physiology. Now, in someone who has hearing loss, like I said, those hair cells are gone. So it doesn't matter how loud you give them signal. If the hair cells are not there, there's nothing to move and stimulate within the cochlea. So you go past a traditional hearing aid, which is how you make sound loud, and you have to then get stimulation to the auditory nerve by bypassing that, and we do that with the cochlear implant. So the cochlear implant, like I said, is worn on the external side. Sound goes to a microphone, which is worn typically on the ear, but sometimes can be worn on the body. It then gets converted to an electrical signal. That electrical signal is then sent to a transducer, which is then on the magnet. I think I talked too fast with this thing. So it goes on the magnet, and this signal gets sent to the internal part, which is not powered, but gets sent through here, which then goes to these little electrodes that I put into the cochlea, and it can stimulate the nerve because it bypasses the threshold that any hearing aid can achieve. And because there are many electrodes within the cochlea, you can actually stimulate different parts of the cochlea and stimulate sound as you and I hear it, although it's not perceived that way initially. Questions? Make sense? Let's put it all together a little bit. Okay. So implants have, the first implants, contrary to popular belief, were actually done in France in 1977. And then in the 1980s, the FDA allowed children about age 2 to be implanted. And they saw such a robust benefit to it that the age limit quickly dropped to 18 months, and now the FDA allows us to implant at 12 months. But I'll tell you, those of us who are IDing kids early are implanting as young as 6 months of age, but you have to go through all the steps. So there's a lot to do before they get to 6 months of age, including a trial of putting them in hearing aids and making sure hearing aids are not enough for them. As I said, there are 3 companies, all of which are good, all of which meet FDA standards, and we use all of them here. There are over 300,000 patients implanted in the world, and over 50% of them are children. I will say in the United States versus Europe, we do a pretty terrible job. So in Europe, as people who are eligible and candidates to get implants, 90% of them are implanted. In the United States, we're at about 10 to 20%. And so we'll talk about some of that a little bit, about why it's relevant. This is an audiogram for those who haven't seen it. So this is a traditional audiogram. It's a grid. Frequency is up here, and loudness, it comes down. So this is about where like an airplane jet is. Traditionally, when we did implants, you had to be in this gray zone. You had to be profound. But what we found is that if we just implanted in here, we missed a population of people because you have sounds. Sorry, my mouse is here. You have sounds in here that we could help, but then sometimes they would have some good hearing up here. So now what we consider a candidate is this green zone. So you can see, you can actually have very normal hearing in the low frequency, but still be considered for an implant, because if you have normal hearing in the low frequency, but no hearing in high frequency, you cannot hear consonant sounds. And the way hearing aids are designed is that they take all the frequencies and they go up. So if you have normal hearing in low frequency and you make that too loud, they still don't hear consonant sounds. So these are people who will benefit from an implant and need to benefit from an implant because they're not going to make progress well in school. If you can't hear consonant sounds, you can't hear speech. And if you can't hear speech, you can't get an education. So we consider these candidates for an implant. In this area, the orange zone, we talk about it. Some of these are candidates and some of these are not. And it depends on how they're functioning. How they're functioning determines the intervention. And here, as long as they have a well-fitted hearing aid, they should be fine. There should be no reason someone whose hearing loss is in this region would be a candidate for a cochlear implant. So I didn't think you guys were a blood, guts, and gore kind of people, so I decided to do these for surgery. So typically the surgery, in the old days, the surgery was done with an incision kind of like this. That's how I trained. But that's not what most of us do anymore. We make a small incision behind the ear, and this is about where we mark our template for where we would put the body of the device as I showed you. Once we make the incision, we get under the periosteum, we make certain cuts. We make a pocket or drill a well on the skull, which is where we seat the body of the implant. We then make a mastoidectomy, which is how we access our cochlea. We essentially tunnel to the cochlea. We make a small hole either within a certain part of the cochlea, or nowadays most of us make an opening in the round window. And once we make an opening within the round window, we put our device in. And then this is a little bit of a real-time picture. So that picture looks huge, right? It looks like I have all the room in the world. I don't have all the room in the world. Because in the ear runs this fascinating structure called the facial nerve, and you don't want to paralyze them doing the surgery. So this is a real-time picture. Hopefully you're not nauseated. But this is the incus, and this is the stapes, and this is my cochlea, and this is where the round window is. The gap between here and here, which is a pretty big gap in a child, is 4 millimeters. And sometimes it's as little as 2 millimeters. So it's a really very tiny opening that I'm going through to try and get into my cochlea. But that's what we have to do. The smaller they are, the tinier the opening, typically. When we do the surgery, part of what we do that is responsible is that while they're still in the operating room, we test them and we test the device. So once the device is in the cochlea, we want to, one, make sure that the device is working well. And two, we want to make sure that we have some idea that the child's nerve can respond to it. So we do something called intraoperative testing, meaning that the audiologist actually comes into the operating room and they'll put on a sterile external device and we'll run measurements on all the electrodes. It gives us verification that the device is working well, and it gives us some idea on how well the nerve responds. Because, again, imagine that this is a baby who's never heard sound. They can't tell us whether they're uncomfortable or not uncomfortable once we turn on the device, which is a process we'll talk about. So we want to get an idea of where they're at so we can make it a comfortable transition for them. Because pain, they'll take it off. Pain for anyone, they take things off because they figure it out pretty quickly. So then we go to activation, and activation is the light bulb. So it's the turning on of the switch where they get the external part. Centers do it differently. I turn on my kids about 2 weeks after surgery just to give them time to heal. Because, again, you don't want to put on, parents are anxious, but you don't want to put on something on an incision that will be painful in and of itself. So we let them heal. We don't want our activation. This is not what we want for activation. So you might see different things online. This is not what we want because this is pain in a child who's never heard sound. And the best analogy I can give for those of you who have good hearing is that when you go to a movie theater and you decide to do your movie marathon for like 8 hours or whatever, and then you step outside, the light is very bright, and you kind of close your eyes, and it blinds you until you adjust. For a child who's never heard, when we turn them on, it's very, very loud, and it's very weird, and it's not sound. They don't know what sound is. So we have to make it very easy. So when we turn on, we're watching them really carefully. It's a little weird, actually, because we're all staring at the child, particularly a baby. And we're like, okay, do they look okay? Are they squinching? Are they looking upset? And the minute they either turn to their parent to cling closer, their face looks like they're about to cry, they start looking like what is going on because they're like trying to look in their brain, that's where we stop. That's really where the activation stops. And we basically, the analogy is we turn them on to a whisper, which is still better sound quality than they've ever had, but it's comfortable. Because the goal at the end of activation is we want the child to leave with the device, wearing the device, because once we give them quality sound, Our therapists work with them with good quality sound. We want them to wear it every waking hour because they're not going to benefit if they're just on and off all day. Then comes programming, and this is where our audiologists and our speech therapists work intensely. So as soon as we turn them on, our speech therapists start working because, again, they're still having better quality sound even though they're not at full volume than they had before. And our audiologists are tweaking the device constantly, trying to make it child-specific. There's no one-size-fits-all, just like shoes, these are much more high-tech. So anyway, so there are 4 factors that are really important in implantations. The age and onset of deafness. So the longer someone is without sound, the worse they will do when you give them sound. That applies to kids, and that actually applies to elderly. Not that this is the population for that, but just to think that in the back of your mind. So that's why, again, when we talk about 136, we're kind of moving. We're trying to figure out, we're trying to tell our parents, have you made a decision as to what path you want? We do have parents who want to be in the deaf community, and that needs to be respected because that's their choice. But my rule because I have a fair number of deaf culture families, is that you need to at least hear me out and know what your options are, and then tell me no, and I'm good with that. But you need to hear what the options are because there's not an indefinite time period that you have these options for your child. And if they do that, they do that. That's okay. But if they want their child to be in the oral world, again, 95% of our families will be hearing families. Most of them want their child to communicate with them orally. They don't know how to sign intuitively. So for most of them, they want their child to talk. If they want their child to talk, we're on a time crunch. We need to move, and we need to get things going. Kids are not adults, preaching to the choir here. So because of that, when you give them sound, I kind of alluded to this earlier, sound is heard and processed by the brain. It is understood by the brain. So Doreen Pollack wrote this in 1970s, and she actually was talking about hearing aids, but it applies almost more so to cochlear implants, applies equally to both of them. And honestly, I really couldn't do her justice, so I'm just going to read what she said because it really speaks to my patient population. So I learned that one could not simply hang a cochlear implant on children and expect them to develop hearing perceptions normally. Instead, the children continued to act as if they were deaf. Sound was meaningless. When the children were encouraged to use lip reading or signing, they continued to be visual learners and ignored sound. I came to realize that one did not have to teach deaf children to look, but instead one had to teach them to listen. A cochlear implant gave more hearing, but listening had to be learned. I had to make sound an important and meaningful part of everything the children were experiencing. And this is really important because the specific technique of speech therapy that our children need is something called auditory verbal therapy. They have to be taught to listen. They have to be taught that. They just don't, it's not intuitive if you have never had it before. So because of that, there's a whole process that needs to happen for our children, and our children need special education needs, and we'll talk a little bit about the laws and things like that. But if we don't do the rehabilitation piece after we give them access to sound, they're not going to do well. And the data actually supports that. So when you look across the board, these are not just deaf children. These are just children with hearing loss. 47% of children with hearing loss will never finish high school. 47%. So that's compared to about 16 to 17% of the regular population. So that's a system issue. These children are not developmentally delayed. They are not mentally handicapped. They have hearing loss. And then correspondingly, 51% of adults who have hearing loss are not employed. And if anyone can't see a correlation with that, please come see me afterwards and we'll talk about it. But, I mean, it's huge. This is not Virginia. This is not poor states. This is national data. That means that our system for these children is not working. And then when you think about how many of these children there are, that's a huge population of kids that we as a global system, not just medical, but educators, schools, therapists, we're just not gelling together for these kids. And again, if we're not being successful with them, then why would we expect people who are in deaf culture to buy in, right? I mean, you only buy in if it's great. Why would you buy in if it's like blah? Put your child through a surgery. So a lot of it makes sense. So because of that and others, so there are laws that help our kids, and I spend a lot of time actually educating my parents on the laws, as does our team. So IDEA is the Individuals with Disability Education Act, and hearing loss is a disability. It's a federal statute under the 14th Amendment. And what it essentially does, it gives dollars to schools and educational programs to help children with disabilities get educational goals. Children in school who have hearing loss, I encourage them to get an IEP, which is called an Individualized Education Program, which means that a child will have whatever equipment they need, special services they need. Children with hearing loss need one-on-one speech therapy. Kumbaya group therapy does not work because you cannot detect language nuances if you have 5, 8 kids around you who have hearing loss. So it needs to be one-on-one. And an IEP gives measurable goals that the school and the parents are part of this, need to follow to make sure that their child is making progress along with their hearing peers. So it's regularly maintained and updated, and there's a stigma associated with it, but really it's very, very helpful for a child if a school can buy in, and our videos will tie into some of this. So then if my school isn't helping, and in Virginia that's less of an issue. I was in Louisiana before, and yeah, I used to threaten people all the time. So in Louisiana, I used to talk about 504 a lot. And what is 504? So it's also a section of the Rehabilitation Act and Americans with Disabilities Act. And this actually is a law that says that if a school is not providing the resources, it takes money away from the school. So it actually doesn't give money at all. It just takes it away. And schools hate 504. So, but if for some reason a child is not able to get, then we introduce the school to this law to make sure that they're following through. Now, the other thing just to remember for all of those of you who haven't heard of these laws is these apply to public schools. So if a child is with a disability is going to a private school is in no way, shape, or form obligated to follow any of these. So sometimes for my kids who are in private schools who don't have buy-in, it's almost more of a problem to get them taken care of than if they were in public school, because at least in public school, the law is on my side. Private school, kind of all bets are off. So now let's talk a little about dollars. And in pediatrics, we sometimes tend to be uncomfortable about dollars, but you know what? This is expensive. It's expensive all ways you look at it. So just implant-wise, typically most insurance companies will pay for the first implant. Most insurance companies will deny the second implant. But, you know, we were born with 2 ears, and I firmly believe if you have 2 ears, you should use them. So I found that if I appeal the denial on the second implant, which usually means I'm making lots of phone calls and talking to physicians and educating physicians, I'm able to get them paid for by insurance companies across the board. I actually haven't had one denied. What's the cost of an implant? The actual device itself costs about $40,000. So that's just that little bitty device. When you add surgery costs, rehab, all of those things, we're talking upwards of $100,000 for 1 ear. So sounds like a lot of investment in a child, right? Okay, so this is an old study, 1993, but it's actually very relevant. So if a child is identified early and rehabbed and able to be in a classroom with their hearing peers, the yearly cost of education is about $3,000. If they're in a deaf classroom, it's about $10,000. If they are in a deaf school, in a residential program, it's about $36,000 per year. So again, not to put a cost on things, but these are, when you're talking about something that's very common, we're not doing a good job with it as a society, these are costs that are very relevant to us. Oh, this is the fun part. Anyone have any questions? No? Okay, so I'm going to play 2 videos. I'm not going to I'll tell you their stories after I play them, because I don't want to bias you. What I'll tell you is that this is a talk about cochlear implants, so they both have implants. They're both very similar, but very, very different. Okay?
When I was 1 year old, my parents found out I had hearing loss. They got me hearing aids and started speech therapy right away. When I was 2 years old, they were told that my hearing was completely gone. I had an important decision to make. I'm so glad they chose a cochlear implant. With my cochlear implant and lots of hard work by me, my parents, and my speech therapist, I'm able to hear the world around me. I enjoy hearing animal sounds and planes flying over our head. I can also hear my grandparents on the phone. I am able to attend the same school as my brothers and sisters. I'm in 7th grade in regular education classes. I love watching movies and listening to my music. I even learned to play some songs on my guitar. When I grow up, I want to be a speech therapist so I can help others with hearing loss.
Does everyone remember him?
And her understanding and hearing has gotten so much better that she's gotten a second implant, and it's just made a big difference.
Two.
Mỗi tháng chiều ở bữa vì for me and Mom being home for here.
So now?
Yeah.
Now you have one or two? You have two, right?
Yeah.
It brought tears to our eyes, me and her mother both.
Yeah.
You know, and because she could actually hear us talking to whereas before, you know, you can just talk to her and she not hear nothing, you know. But, you know, that first time it was just like, wow. It was just amazing that there was something out there that could help her and, you know, other kids, you know, that we got to know in our little community that we have back home. And, I mean, it just made a world of difference.
I have phone and cabinet and dark meat, paint, budget.
So today, actually, she's gotten her second one turned on. But, yeah, the first thing she says, I hear better, you know, so.
Okay. So I'll take your story. So they're both 11. So we'll start with the boy. So the boy is one of 5 children. He was born full term, no complications. There's no family history of hearing loss. He passed his newborn screen, but he's the 4th child, and so the parents immediately noticed there was a difference because when the door slammed, he didn't startle, and they kept talking about the difference. He saw 5 or 7 physicians, including several otolaryngologists, before he finally got ID'd as profoundly deaf at 18 months of age. He then went through a period of hearing aids and got his first implant at 3. Now, they live in a very, very rural part of the country, and like I said, he's not the only child, and they're not a very wealthy family. But the school system and his parents were determined that he would be oral. And as you can see, he's very easy to understand. You can't even necessarily tell that he has a hearing impairment, and that's just a testament of how much work the process has done for him because he got aggressive rehab, he still had an IEP, and every time they wanted to take away his IEP, I told him to go for the meeting without his cochlear implants, and he would keep his IEP. And so, and his mom said, you know, he listened to music, he played music, but his mom would say, even to this day, that when they had a nursery rhyme, that she never was able to sing to him. So there were words and nuances to nursery rhymes he didn't know. So even as aggressive as they were, there were things that he still missed because he was ID'd early, but he's going to do fine, and he's going to do anything he wants to do. Now, how many of you had difficulty understanding the girl? Right. Okay. So her story is actually very similar. So she failed her newborn screening and was told it was okay, and she would be fine. So she then, this is actually grandma with her. Her mom couldn't be there, didn't want to be in front of a camera. But grandma said that there was a problem. And so they also went to multiple doctors. And also, grandma said she would sneak up on her and hit pots behind her head, and nothing would happen. But if she saw her, she turned to her. So very smart, very, very smart. But wasn't ID'd till she was 18 months, wasn't implanted, also to about 3. So again, very similar story. The school system didn't buy in. And she did not have the access to speech therapy privately. So for 2 years after she was implanted, she really got nothing. So finally, the family kind of gave up, and they put her in a residential deaf school where she gets sign language because they're a deaf culture, deaf school. And so whatever speech she has, she sort of learned on her own. when she spends weekends and holidays with her family. None of it is taught. But as you can see, when you think about her job potential, so I often think as a pediatric specialist, I'm not just taking care of children. I'm trying to prepare my children so they can be adults, right? They don't just stay kids forever, even if we want them to. They got to have to go out in the world. Their parents are going to pass, hopefully after them, and they're going to need to be able to take care of themselves. Well, what kind of a job do you think she can get? Very limited job market. Now, and she's at a deaf school. The way the deaf school is that she doesn't get a GED. She gets a certificate of completion. So if she wants a GED, she'll have to get it on her own. She will not go to college. So that's what we're doing to 40% of our children. Okay? All right. So it takes a village. This is a little bit of our village. Over here, we have a clinic here. It's called a Cheers Clinic. It's happy because we're trying to do good things. What does the acronym stand for? It's Carilion, Hearing, Ears, Oral, Rehab, and Speech, which are some of the services we offer in the clinic. And I see some of my team members here, but these are our audiologists. These are our speech therapists. And they are working, they all have a lot of exposure with deaf education and how we need to take care of deaf children. She needs a halo because she's working on getting her certification to make sure that she's a certified auditory verbal therapist, which is what these children need. We're also working on getting telemedicine so we can get therapy to them at home. My nurse needs a halo because she's coordinating and we're working together on making all these systems work. Dr. Doherty, Dr. Pineda have been big supporters of us. And then we have our educational person here who fights with us with the school so I don't have to do it, which I'm so happy about. So, but it's a huge part of it because the school has to tie in with what we're doing, which has to tie in with what the private therapist is doing so the message is clear, so the child is successful. So future, what's coming? So we already talked about this. There are two parts to this. And an implant is still visible, which is sometimes hard for people to conceptualize. We're working on getting smaller devices. This was presented by MIT a few years ago. This is the future cochlear implant, and that is a finger, and that's the implant. And the idea of this is that it will be a completely implanted device, which will enable them to recharge it by lying on their pillow at night. So there'll be nothing external. And the mic will go on one of the hearing bones. So really, really nice concept. It's not even in clinical trials yet, so don't look for it anytime soon. But we're going to get there, and I suspect we're going to get there in my career, so that's pretty great. We are using much less invasive surgery. We're doing much less trauma within the cochlea, and we're talking about all kinds of research to try and regenerate hair cells, so potentially maybe implants will become obsolete sometime. Parents can't wait for some of these options because remember, if they want their child to talk, waiting for an option that doesn't exist, that even gives them sound later, doesn't mean they are going to know what to do with the sound, which is what a lot of parents are waiting for. It doesn't mean they'll know what to do with the sound. Okay. And then the other part is there are over, so far, 400 hearing loss genes identified, and the interpretation of these is very challenging, but we are knocking on the door of several gene-guided therapies to do the knockout genes and treatment from a gene level to prevent some of these hearing losses. This is my next video. So for this, if you're emotional, you will cry. Get out your Kleenex. But
What book? First hearing aid.
Are you ready? This is the big moment. Literally away.
They're all silent, pushing your head just a little bit.
There you go. Sleeping. So now technically your device is on. Yeah? Did you hear it? Hey, I sound clear. You're hearing yourself better. Okay, you can try. That's okay. Hi, baby.
I know I look like an elderly munchkin, but do I sound like one now? My God, I can hear myself.
Yeah. That's good.
It's okay. Blue. Orange. Red. Black. Purple.
What do you think? So different. Yeah. So clear as a summer pool.
So they're awesome. People love sound. Not having sound is very isolating, no matter what age you are. But we need to work on early identification with appropriate intervention. We have lots of work to do in terms of research. Everyone can break out your Kleenex. That's all I have. Any questions?
I know there's questions from online, but are there any questions in the room?
Anita, when these first started coming out, at least I remember, there was an incidence of pneumococcal meningitis associated with that. Need to talk about that. Is there anything to update us on that with?
So at that time, one of the companies had what's called a positioner, which was the implants, the electrodes that went into the cochlea were designed in a way that the opening had to be really big. And it was thought that because of that positioner, bacteria could get into the cochlea better. That's all been recalled. We now give additional vaccinations. So once a child is 2, they need to get a pneumovax in addition to the regular Prevnar series, whether they've had an implant or they're going to get an implant. So for my older kids, that is a requirement by me as part of the CDC guidelines for kids to prevent them from getting meningitis. It's now thought to be a theoretical risk, but we still follow the guidelines. Good question. How do I know what's online?
I've got the window pulled up, but the resolution is kind of terrible. I think I can read most of them. So the one says the 136 refers to a baby that failed newborn screening at 2-month checkup. What features should we look at
for rescreening?
For rescreening.
So if a child has had their first screen and has failed a second screen, they need to be referred for diagnostic testing. There should be no more screening. They just should be referred for diagnostic testing.
I think the second part of that they emailed me is, would there ever be a situation where they pass the first screening, they would go on to a second one and still need follow-up?
So if they're a high-risk baby, meaning they were like a NICU baby or have other risk factors, they are dysmorphic looking, they had IV antibiotics, if they fail another screen, they go down the same protocol again. And if they fail a screen in one ear, they have an equal chance of having hearing loss in either ear. So we check both ears if they fail a screen.
Okay.
Hang on a second.
All of those 3,000 genes that can cause congenital hearing loss, does a cochlear implant address the problem in every one of those?
So as long as they have an intact cochlea and an intact nerve, so we do imaging as part of the workup for a person who has cochlear implants. If it's sensory hearing loss, yes. Yes. But it's not for everyone. So if they don't have an ear but they have an intact inner ear, there are other things we talk about. But that was not for the scope of this talk.
Okay. There's several more questions. How do you know what they hear? How do we know what these patients hear?
So when I get asked that a lot, and from adults who have implants, but typically adults who get implants are people who have heard before and have lost hearing. they'll say that it sounds a little bit staticky. But remember, a child who's congenitally deaf does not have sound. They have nothing. So what they hear is what they hear. And if you listen to the boy, he talks like you and me. That's sound as he knows it. So regardless, his brain has learned to process that as sound. So he might be hearing, getting a different input than we are, but he's processing it just like we are. It's still sound. It's just how the brain interprets it. Hope that answered that question. How do I know if I'm answering their questions well?
Sending them in.
Okay.
I can unmute the phones here in a second, too. We've got about 3 minutes. So what are the youngest and oldest patients you've done?
Oh, gosh. Okay. So youngest patient I've done was 6 months because they had meningitis. Meningitis is one of those few exceptions where we don't necessarily march down the whole algorithm, because if they get bacterial meningitis, they can ossify their cochlea, and they can ossify their cochlea within a month. If they have ossification of their cochlea, that means that bone grows in the cochlea. So where that fluid was, there's bone. I cannot get an electrode in bone. I can't drill an opening in a cochlea. So those are an emergency as we consider it. So we push them through really, really quickly. And once we diagnose them with profound loss in both ears, we implant them almost immediately. Oldest, okay. So up till the time I came here, I only took care of kids. So the oldest I've done is 21 kids. But now I'm the only implant surgeon in the region. So I have a 75-year-old on my docket, which is freaking me out a little bit. But the surgery itself is not the issue. It's more like, you know, they're much more dizzy afterwards, and there are other things I need to worry about. But that's my personal issue, not yours.
All right, the last one is in older teens or young adults who have traumatized their nerve endings with loud noise, would an implant help with that, or is it a lost cause?
If they have had hearing and they have lost hearing, an implant can help anybody, as long as I can get them and make sure that they don't benefit from just traditional hearing aids. I'm still going to go through a hearing aid trial to make sure, because some of our kids just haven't had appropriately fit hearing aids. So yes, absolutely can help them. But they have to be willing to wear it.
Any other questions in the room? I can unmute the phones here real fast.
The conference is now in talk mode.
Okay, if you're on the line, and we have a lot of people who are, if you would just mute your phone on your end so that we don't hear what's going on in your background. If you have a question, now's your chance. Questions? Okay.
All right, thanks for your time.
Thank you all very much. Thank you all very much for joining us. If you have a question that you didn't get to send or ask, you can email me at outreach@carillionclinic.org, and I will get them to our presenter. With that, I'm going to go ahead and disconnect the phone lines now. Thank you all very much for joining us.